And so this is the exam one review for our October term. And we're going to use this PowerPoint to discuss our concepts. Now, this is all kind of like repeating material. If you were in my class yesterday, probably a third of these slides are things we just said. And so we are going to talk about them. And I still want to reiterate some of these concepts, but I really want to know what you guys think about it and what you've learned about it. Okay. So the first thing we're going to think about with any exam is the nursing process and how we think about the next gen is kind of shifting our views. So we're still following the nursing process, but we're using a little bit different terminology, um, like recognizing and analyzing cues. This is the same thing as your assessment. This is looking at your patient and going, something's not right. That's recognizing a cue. Something's not right. So now let's analyze it. What's wrong? What do I need to do to determine why I feel like something's not right? Okay. And so then we can analyze the cue, and then we can develop a plan for our patient or a hypothesis of what we think is happening that's causing the cues that we've recognized. Then we can develop our plan, and then we can execute our plan. But if you look at the nursing process, you see that that's still the same idea, right? So when you're when you're looking at your test and you're thinking about what is going on with my patient, then we can think, where are we at in the nursing process? Okay. What would I do to intervene? Maybe it's an education issue for the patient, all of these things. What's normal? What's concerning? Okay. So the first thing we started talking about was culture. All right. And we talked about how culture plays a huge role in the way that people seek care, in the way they interact with their providers, with the way they interact with each other, um, the way that they view their illness. So for OB, how does that affect that, do you think? What do you think? What do you think?
Some women only want female doctors.
Yeah, that's a good example. Only female providers. Okay, what else?
Some cultures believe in, delivering differently than, the traditional way that we do.
True. That's very true. And then we have to try to be accommodating to that. Okay. What else?
Maybe who they want to be with at the labor time.
Okay, good. Sometimes they need like their mom, or they need, certain people to be in the room. Okay. I think also for some cultures, the way they perceive their pain is different. And so some are very stoic. I have taken care of patients who I would have never guessed they were about to deliver a baby. They were so controlled and so together. And then others that are completely losing their minds and they're not anywhere close. And some of that can just be the person. There's so many things we talked about in class, all these things that affect your perception of pain. But culture is one of those things. And some cultures are notorious for being very stoic, for example. Okay. Good. So then we talked about the differences between cultural competence, cultural relativism, and ethnocentrism. Who knows how we tell these apart?
Cultural competence is just acknowledging that there's other traditions and diversities and things like that.
Okay. Yep. You were acknowledging and respecting. So like what we were just saying with those that maybe want to deliver in a different position or have different people in the room or whatever, we're acknowledging and respecting those traditions. Okay.
I can't pronounce it, but the second one, it's like you want it to go your way, I guess. Like you don't want it any other way but your way.
Good. All right. Ethnocentrism is your way's the right way. Okay, good. What about cultural relativism?
That's actually, I guess, taking your cultural competence and applying it instead of just, oh, okay, that's a different thing. It's just actually applying it.
Okay, good.
I guess you take the belief and try to apply it with the care that you're giving them. I don't know the best way to put it.
Yeah, you guys are both right on. Okay, so not only are we acknowledging and respecting, but we're taking the care items and applying it to what is important to them in their culture. Okay, perfect. So the other thing that we need to consider is that sometimes we have some cultural barriers, and one of those things that can be a barrier for us is language, right? And so if we have somebody who does not speak our language, then we have to find a way to communicate with them to be able to understand their culture, understand and acknowledge cultural competence, relativism. We can't do any of that if we can't communicate. So most facilities have in place like a whole system where they can contact different interpreters. And so that is a really great tool that we can use an interpreter from their native language or culture and that helps us give a more culturally sensitive care. Let's say though, guys, that it's 3 a.m. and your patient rolls in huffing and puffing and is 8 centimeters and doesn't speak English. Okay. Do I have time to get an interpreter on the phone, or can I use their I don't know, 7-year-old that came in with them to interpret for me?
Prefer to still use the phone.
You guys still
Yeah.
use the phone. Yeah. Sometimes it's not convenient, but a 7-year-old cannot be the interpreter for the patient. And truly, it shouldn't even be like their spouse or anything else. We really need to use somebody who's trained to interpret. Okay. I do know that sometimes what I've seen in practice is if you have somebody who speaks the language pretty good, but they sometimes need a little bit of help in understanding, their partner might help from the other perspective, where we're explaining and they understand what we're saying, and then they turn to her and explain it to her in her native tongue. And that is still kind of a gray area, right? Because what if he didn't really understand what I said, and now what he told her is going to happen is different than what's really going to happen? So it just creates a lot of muddy water there. So for our interpreters, even in an urgent emergent situation, we need to try to use a professional. Okay.
So what if we speak Spanish?
Okay, if you speak Spanish, that's fine.
Okay.
Absolutely. That's great. I love it when the provider speaks the language that the patient comes in speaking, because you can communicate so much better that way.
Mhm. Okay, thank you.
Yeah.
So you said that even if a family member is in the room, you said don't use 7 years old, but what if older family member like husband or someone that speak the language? So first you don't use them, you use the phone first?
Mhm.
Okay.
Yep. You need to try to use your phone first, your professional interpreter. Okay.
One time I was talking to a patient and they didn't speak any English. And I guess her husband didn't think that I understood Spanish. And he tried to tell us that she was hurting, but she said she wasn't in pain at all. So he wanted her to have the medicine. And she didn't want the medicine.
And that's a prime example of why it's better to use the phone than to use their family member, is because that sometimes what they tell you might not be what your patient is saying at all. Okay. All right. So that's kind of that's our interpreter part. Okay. So then we start talking about health promotion and disease prevention. And there's a lot of things to consider in this topic. Okay, we talk about nutrition, and we're going to spend more time looking at nutrition as it relates to pregnancy in a minute. But just across the continuum for women's health, nutrition, what screenings need to be done, exercise, things like that. We need to teach our patients how to stay healthy. All right, so we teach them about how to do breast exams. Women that need to have pap smears. We talked to them about their comorbidities. So in class, we talked about how comorbidities, if we can get those under control with preconception counseling and care prior to pregnancy, that really makes a difference in our outcomes, how our babies do and how our moms do. Because you guys remember the 3 big things that contribute to high-risk pregnancies, the comorbidities.
You said 3 things what?
The 3 big things that we talked about in my class that you guys should have all talked about. The 3, I call them the big offenders, the 3 big things that contribute to high-risk pregnancy.
Talking about like folic acids and
Okay, so taking folic acid before pregnancy is a good idea too. But as far as,
Is it
go ahead, what?
obesity?
Obesity is 1,
Hypertension.
hypertension,
diabetes.
and diabetes. Okay,
Yes.
and so these 3 things are going to be, it's going to be really important to be managing these well before women get pregnant in order to decrease NICU admissions and decrease high-risk pregnancies across the continuum. Okay, and so here we are in health promotion, disease prevention. If we are meeting with women before they're pregnant, we can really work on getting these comorbidities under control. Okay, also consider our high risk populations. Okay, our adolescents, our low income, those that don't necessarily have access to care or don't understand what their care needs are. These are where we talked about how to outreach some of these people and to make sure that we are providing care to even to women that don't typically have access to it. So this is important, clear at the beginning before they get pregnant. If we think about our underdeveloped countries, there's a lot of morbidity and mortality there. Okay, and a lot of that is because they don't have access to care. All right, or they're delivering at home without help. And you know, some of the things that you guys will see in clinical or you have experience with already, if those things happen with somebody who's at home, then that's where our morbidity and mortality go up, right? So adolescents also are considered a vulnerable population. They need a lot more guidance. They need better nutrition. They have a higher prevalence of things like iron deficiency anemia, growth restriction for their babies, things like that. And they have a higher prevalence of making these poor lifestyle choices, right? Like smoking, drinking, drug use, all those things. All right. So part of what we're going to be promoting with health promotion disease prevention is not just talking to those that want to get pregnant, but guys, when you guys looked at, as a side note, when you guys were looking at prenatal care for your discussion, how many of you found the statistic that says something like over 50% of pregnancies in the United States are unintended? You guys remember seeing that?
I found one that said it was higher than 50%. So
Or higher still. So we need to be outreaching every woman, okay? Because a lot of times pregnancy happens when they weren't even really planning to get pregnant. So providing access to education and care and stressing the importance of prenatal care once the pregnancy happens is going to be paramount. Okay, but if we are taking care of them on this end, we're keeping them vaccinated, we're taking care of their comorbidities, we're helping them with their lifestyle choices, getting them exercise, nutrition, stuff like that, we're going to grow healthier babies. Does that make sense? All right. So a nurse has discussed strategies with the client during preconceptual counseling. The client demonstrates understanding after making which statement?
D?
D.
The D.
Good. The first 8 weeks, right? What period of development for the baby is the first 8 weeks? What do you think? We have, if we think about conception happens, and then we grow a blastocyst and it implants, and then it grows into something else that grows into something else. Like, what do we call that in the first 8 weeks?
Is it embryo?
Good, the embryo. The embryonic period is the time frame when all of those organ systems are developing. And so that's when they're at the greatest risk. But what are teratogens? What is this talking about? That's stuff like this. This is alcohol, drugs, nicotine, exposure to radiation, pollution, anything that will alter cell composition. Our babies, our embryos are at the highest risk because that's when all the organ systems are forming. Okay.
So teratogen, anything that put the baby at risk?
Yep. Okay, and I don't think you see the word teratogens a lot. I just want you to understand what that means. That the idea is that our babies in the first 8 weeks gestation are at the highest risk based on lifestyle choices, based on things mom's exposed to, stuff like that. Okay. So, all right, so prenatal care. So once we start taking care of a patient, well, I think I have a better slide on prenatal care. So this is just our regular history and physical. But this is going to be the best way to help control our risk factors and to help grow a healthy baby. So when we do our head to toe assessment, we are going to establish rapport with our patient. We're going to do our screenings. All right. So screening on every appointment, whether it is your regular Royal Woman appointment like this, or your prenatal appointment, we're going to screen them every time for abuse. We're going to screen them every time for depression. And actually in pregnancy, and especially in the postpartum period, we're screening for depression also because they have a higher risk of postpartum depression. We're screening for intimate partner violence. We're screening for human trafficking. Okay, so what kind of things do you think we might see for a patient who is subjected to intimate partner violence?
Fear.
Mhm.
If their
Bruising.
partner is in the room, they don't allow them to speak.
Okay, good. They want to tell their own story, right? There's a great list for both of these in the book in these boxes. Hold on, let me see if I can grab it. Page 51 and page 40. If you guys have not taken the time to just at least look at the boxes and those things in your books, then I would encourage you to do so. I think this is actually a different book.
Professor McBride.
Yep.
So I think I told you this before, but I do have the ebook for this class, but I have the hard, the paper one, but it's a different edition.
Yeah.
I think it's barely different, but do you think that would have like the same stuff in it?
Yep. So when I look at like for this exact thing right now, if I put in intimate partner, I found it on a different page in the one book than in the other book, but it's the same thing.
Okay, thank you.
So like figure, I think this is the one I'm looking for actually. So like this right here, this box 3.10. No, that's not the box I want. Here it is, box 3.11. Signs of intimate partner violence. I know it's in both books. What I like about the online version that you have, Lori, is exactly what I just did. I can type in and search and pull up what I want. On the paper one, you can go back and look at your, you know, your not your glossary, your I'm drawing a blank, but you know what I mean? Your directory, and then you can find your page, and that works too. But I like that it's very simple. Like right now, I wanted to show you guys box 3.1, and I could get to it simply on the internet. So you can use either one. They're going to be very interchangeable.
I should probably do that. I think I'm so used to using textbooks.
Yeah.
Ebooks are kind of a new concept for me.
There's a lot of really cool things that you can do in here that I'm still even learning. They gave us training on, but I didn't play with, where you can highlight, you can pull out chunks of what you want, you can put them into flashcards, all sorts of stuff. It's pretty amazing. Technology is pretty crazy. All right, so intimate partner violence. So this is what I was referencing on the slide here, signs of intimate partner violence. And so you guys said not letting her talk. And I think that's in here. Intimate partner never leaving the bedside, insisting on telling the story. Okay. You can see anxiety and depression too with intimate partner violence. They might have unexplained injuries. They might not be following the treatment plan. So if you guys haven't looked at your boxes, like when you're studying, if you can't go through, I mean, it's a lot of chapters. I would glance at your headers and I would glance at your boxes and figures. Okay. And then if you get to something like here and you're like, oh, I want to know more about that, then you can actually read into it. The other one for human trafficking.
Excuse me, Ms. McBride. Like, how did you pull up this box to search?
Okay. I knew what I wanted. So a couple ways you can do it is if your slide tells you a page like this one did in the PowerPoint, it said page 51, box 3.11. I knew I wanted 3.11. And then human trafficking, I already know is on page 47. So I was going to jump to page 47. But if I am just trying, so like if I want to jump to page 47, right now I'm on page 48. So if I go back one page, here's page, I went too fast, 47. So here's human trafficking. And here's box 3.9. But if I didn't automatically look at from the page, I can use my search box over here. So here you pick up your little looking glass and you type in what you want. So I want human trafficking. And over here, it's going to pull up everything that talks about human trafficking. And since I was already in that spot in my book, you can see all the yellow highlights. But if I wasn't in this spot in my book, if I was on the beginning maybe, and I typed in human trafficking, now I can look over here and find what I want to look for. And there's all this information on human trafficking in my book. And then maybe I know that it's going to be in chapter 3, maybe not. I can just kind of decide where to go over here. I can click on any of these. It's going to take me right to that spot in the book. Okay.
Question for you.
Yep.
When I signed in for my book, it gave me a code for Evolve, and I have that in my Evolve where I could go in to that book and access the HESI questions. Do you recommend for those chapters?
Okay.
Do you recommend using those as practice tool to get us used to the question format?
I have not seen that yet. I'm going to have to look at that when we're offline. Anything that gives you an option to practice, I think is a good idea. All
I
of
could
us
go to
learn
those specific chapters and then it will toss me questions only for those chapters.
See, I think that's awesome. Yeah, I think it's great. Everybody learns differently. If doing practice questions helps you, that's a great tool. That's kind of like when I play Kahoot, it's practice questions, right? With Kahoot, I explained this is why this is the right answer. With those practice questions, does it give you a rationale?
Sorry, I haven't tried them yet, but I know in the past it does give you a rationale and it takes you back to those part in the chapter where you could go back and reread.
Yeah, it
Yeah.
does give rationale.
See, the rationales, guys, in my opinion, are gold. The rationale doesn't just tell you, well, the answer is B. It's telling you this is the right answer for this reason. And I actually have a website that has like 500 OB questions and it has all the rationales in it. And I think that's where the learning really happens because you can see why that's the right answer. So if that's available to you in your ebook, I would absolutely use that. So anyway, so here I typed in human trafficking. This is a box 3.9, which is referenced in your slides. This is screening, things that you ask your patients for human trafficking. And I think the big key here is the yes, no question, all right? Trying to get them to just answer you yes or no. You know, do you have enough food? You know, things like that. So I would go back and look at those. Anyway, so that's how you use your book, guys. And I do think that if you take your study guide and you take the PowerPoint and you take the book and you kind of combine all of that together, it's going to really give you a good basis for your study. So when we're doing our head to toe, we want to wash our hands. Hand hygiene is huge. It's going to be important with any patient you take care of, but especially like if you think about our newborns, when we start learning about newborns and high-risk newborns and babies in the NICU and stuff like that. I mean, we have to be very diligent about hand hygiene. If we're doing a pelvic exam, so pelvic exams in this context is really just for like a pap smear and testing for STIs. But even guys, if we are checking a cervix and we're using 2 fingers to measure the cervix, anytime we are going to go inside their vagina, it's a very intimate and difficult thing for some women, especially those that have had experience with sexual assault and things like that. So we have to be very patient and understanding and only do these procedures when they're absolutely necessary. Okay, so we'll explain the procedure, have her empty her bladder. You guys know if you've ever had a pap smear before or had any sort of cervical testing that you are on your back. If you are on your back in the lithotomy position, your pregnant patient especially has a high risk of supine hypotension. What's supine hypotension? Anybody know?
Whenever the mother lays on their back, the baby compresses. They compress the arteries in the vessels and makes it difficult for the mother to perfuse and breathe.
Okay, it causes the mom's blood pressure to go down. Supine is she's on her back. I learned clear back at the very beginning of LPN school, supine on your spine, and that's what I still remember. She's laying on her back. And hypotension, the blood pressure goes down. And so because of, like Lori says, the weight of the baby is putting pressure on the vena cava. And so that affects the way she's perfusing her own body, affects the way she's perfusing her baby. So what are some things that if your patient's on her back and we're getting ready to do anything, we could be doing a pap smear, we could be checking a fundal height, we could be doing Leopold's, anything where we have our patient on her back, what might she say or what might she be feeling that would give us an idea that we need to shift her onto her side?
Dizzy?
Lightheaded or dizziness.
Good. Yeah. Signs of hypotension, lightheaded, dizziness, she might act anxious, things like that. Okay. If we're doing a pap test, or we're testing for STIs. The other thing that should have been provided as education to her before she came into the hospital or to the doctor's office is not to put anything in her vagina first. So if she's had intercourse in the last 24 hours, if she's used a douche, if she's done anything where something's been in her vagina, that can skew these tests. So those are part of our considerations when it comes to this type of testing. Okay. So the nurse teaches a pregnant woman to avoid laying on her back. The nurse has based this statement on the knowledge that the supine position can do what?
Decrease placenta perfusion. No. Yep.
The-
Transservices. C, cause the hypotension.
The hypertension.
So both B and C are right. Okay, because it can cause transient episodes of hypotension. It also can decrease the placental perfusion. Okay. And so I actually meant to change this to say hypertension because we identified last time I used this question that there were 2 right answers and I missed it, but you guys caught it. So good job.
You could just select all.
I can change this to select all that apply. Yep, there you go. So perfect. Both of those are correct. All right. So now our patient is pregnant. Okay, so conception and early pregnancy. All right, so we already said the embryonic stage is the most critical in those first 8 weeks. Where does conception happen?
Is it in the fallopian tubes?
Good. It happens in the fallopian tubes. Okay, so the sperm comes up through the vagina, through the cervix, through the uterus, and it swims all the way up here into the fallopian tube where the egg has been released, the egg has been released from the ovary, and conception happens in here. Now, this should travel. Where should it travel to?
The uterus.
It should travel to the uterus. And it takes about a week to 9 days for this to travel to the uterus and to implant in here. And that's when HCG starts being released. HCG is what we use to test that positive pregnancy test. All right. What happens if it doesn't make the trip? What if it implants up here in a fallopian tube?
An ectopic pregnancy.
As an ectopic pregnancy. If it implants in the fallopian tube, can it stay there? Can it grow and be a baby?
No.
Unfortunately not. Okay, and that was what you guys worked on with your case study on ectopics. Okay, so then we have 3 main structures that are just exclusive to pregnancy. Okay, that's our amniotic fluid and our placenta and the umbilical cord. What does the amniotic fluid do?
It cushions the baby.
Cushions the baby?
Regulates body temperature.
Good. Yep. Cushion, regulates body temperature. What else?
Does it help the baby to breathe?
Well,
Something like that?
Yes. Okay, you were right. I was thinking of it in a different context. Yes, it helps the baby to breathe because the baby breathes the amniotic fluid into their lungs and it helps expand those alveoli. Okay, so it helps with lung maturity. We can also use the amniotic fluid to measure lung maturity, which we'll look at in a minute. Okay, so
Electrolytes.
what's that?
Does it balance electrolytes?
Yep, good. All right, so now the amniotic fluid level is dynamic, it shifts, but if it's too high or too low, it can be an indication that there's something wrong. So if it's too high, if the level is really high, we call that polyhydramnios. And this can be caused by a few things. It can be caused by something is wrong with the baby. So remember, guys, the baby drinks the fluid and pees it out. Right? And so if the baby's not drinking enough, if they have anything that keeps them from swallowing the fluid, if they have some GI disorder or something like that, that can cause the fluid level to be high. Also for moms, if moms are diabetic, that can cause the fluid level to be high as well. Okay, for fluid that's low, since the baby drinks it and pees it, if they are not peeing it, if they have a problem with their kidneys or their bladder, that can cause the fluid level to be low. If the mom has preeclampsia, that can cause the fluid level to be low. If she's past her due date, that can cause the fluid level to be low. And that's called oligohydramnios. And we'll spend a lot more time learning about that later in the term. Like when we talk about diabetes, we'll say, high amounts of amniotic fluid. And when we talk about post-dates, we talk about low amounts of amniotic fluid. But that's just something to keep in mind, that whatever's happening with your mom and your baby can affect the amniotic fluid. Okay. All right. Umbilical cord. What's the umbilical cord made up of?
Two veins, artery.
Veins and
Two
arteries.
arteries and one vein.
Okay, I've heard it both ways. Which one's right?
One vein, two arteries.
Two arteries.
Okay, it's one vein and two arteries. All right, which vessel or vessels carry the oxygenated blood to the baby?
The veins.
Vein.
The vein. And then the arteries carry the waste away. Okay, so if you think about AVA, that will remind you artery, vein, artery. Two arteries and one vein. The vein is big. Okay, the arteries are tiny. So that big vein is bringing all that really oxygen-rich blood to baby. The tiny arteries are taking the waste away. What protects those vessels inside the umbilical cord?
A little jelly around it.
Good, Wharton's jelly. It's the only place in the whole body that this exists. This connective tissue that protects those vessels. And hopefully you get a chance to feel an umbilical cord. And it's kind of it's a little more gooey and slimy, but it has mass that's similar to a gummy worm. All right, and then the placenta. What does the placenta do?
Nutrition.
Okay,
Oxygen for the baby.
yeah, so essentially the placenta is respiration for the baby, right? It brings the oxygen in and it takes the waste out. What else?
It protects the pregnancy by producing the progesterone.
Good, progesterone protects, perfect. Okay, it protects the pregnancy, it maintains, good. All right, so we are relying on mom's perfusion of the placenta to bring all these nutrients and oxygen to the baby and to take all that waste away. And so that's our metabolic exchange, right? So mom's blood pressure can affect this, okay, whether it's low or high. Her position, supine hypotension, can affect this, right? How does the waste and the oxygen, we're not mixing blood. Baby's blood and mom's blood are separate. So how do the nutrients and the oxygen get in and the waste get out? Any idea?
I don't know why I'm thinking the ductus.
Oh, okay. Now the ductus though is going to be inside the baby. And so this is something that's going to happen. This exchange happens inside the placenta. I wish I had a picture of it, but basically we just have one cell layer between maternal blood and fetal blood. Okay. And so if you think about in our own bodies, how things get in and out of cells. All right. Sometimes it's active and sometimes it's passive. If you think about diffusion and all that stuff. Well, so we have the maternal blood that is, and the fetal capillaries, and the exchange happens there. All right. So these two, there's only one cell layer between them, and the maternal blood and the fetal capillaries are able to diffuse the oxygen in, the nutrients in, and the waste out. Okay, pretty crazy how it happens because the maternal blood and the fetal blood should never mix, but they can share nutrients, oxygen, waste, and that way the baby gets the good stuff, and then mom's body takes away the waste. So it's pretty fascinating. Pregnant client asks about the functions of the placenta. Which items of information should the nurse include in the discussion with the client?
Three.
So everybody else, who thinks three
Yeah,
besides Katie?
I say 3.
Okay, 3. Why isn't it 4?
because it doesn't take oxygenated blood from the mother.
Perhaps diffused into the fetus blood takes it away.
Oxygenated blood from the mother is diffused. Yeah, the blood's not diffused into the fetal blood. Okay, right? The blood doesn't mix. Good. All right.
I have a quick question. And this is somewhat separate, but sort of related. But I was just curious because I know with IVF, they can, they extract the eggs and then they reimplant them. How come they can't do that with an ectopic pregnancy if you detect it early enough? I know it's probably like an insurance thing. I don't know if it's possible also.
Well, it's a great question. And I don't understand all of the pathophysiology of it, but my best speculation would have to do with the fact that once it's implanted and growing in one spot, I don't think that, because if we go all the way to the beginning, if you really dug deep and there's YouTube videos and all sorts of stuff that shows how once the blastocyst implants into the uterus and the vessels reach into the spiral arteries through the uterus to tap into mom's blood supply and start growing a placenta and doing all those things, it would be like trying to, it's in my brain, it would be like trying to pull a tree out from its roots and then replant it, because all of that has now tapped into the mom. And if they were even able to extract that and put it into the uterus, I don't know how they could get the vessels to tap back into the maternal blood supply to let the baby grow. I don't know. Like, that's way above my pay grade. Maybe that's something that can happen, medically down the road.
I was just curious. That makes perfect sense.
Yeah. So it's a great idea. I don't know if that's something that could be done, but I think that it'd be difficult because of the way the vascularization happens. And most of the time, by the time we know about an ectopic pregnancy, because we're talking about like microscopic things to start, right? By the time we actually know it's there, it is so involved in the vasculature of the fallopian tube. I just don't know how they would be able to continue to give the baby what it needs if they were able to move it. But I don't know. It's a good idea. All right, so moving on to our genetics. Okay, so we have a couple of things that go on with genetics. One of the things has to do with dominant and recessive. And so hopefully you guys have learned about this before and you did your little blocks where you can figure out what's dominant, what's recessive, and who gets what. And that's what A looks at here. Okay, if we have a recessive gene, then that person doesn't show signs of whatever that is. So let's take factor 5, for example. Okay, factor 5 is, it has to do with blood clotting. All right, and so let's say that the dad carries the gene for factor 5. He doesn't have it. He carries it. Okay, maybe his one of his parents had it and passed it on to him, and he carries that gene. He doesn't have factor 5. He just carries it and doesn't have any idea that he's carrying it. All right, now the mom also carries it, doesn't have it, has no idea she carries it. Together, those are recessive genes. These are things we don't show signs of. Okay. Actually, let's do it on something a little easier. Let's do blue eyes and brown eyes. Blue eyes are recessive. All right. So if you have a brown-eyed parent and a brown-eyed parent, you would expect their baby to have brown eyes. But if they both carry a recessive gene for blue eyes, together they could make a baby with blue eyes. And that's what's happening in A. So you can see the father, let's say he's got brown eyes and he carries the gene for blue. And the mom has brown eyes and she carries the gene for blue. One of their babies will have brown eyes and not carry the gene for blue. Two of their babies, so 50% of the time, could have brown eyes and carry the gene for blue, but one time their baby could have blue eyes. Okay, that's how the recessive genes work. All right.
Why not more than one have it? Blue eyes,
Well,
since they both carry it.
Well, because if they, it's actually, this is breaking it down to 1 and 2 and 1, but it's really like a 25% chance that they only have brown eyes and they don't carry it, a 25% chance that the baby would have blue eyes, a 50% chance that they would still have brown eyes and continue to carry the gene forward. And it would still be recessive for those kids too. And that's just the way that the recessive genes work. They carry something they don't know. But if they come together, then they could produce a child that has it. So obviously brown eyes, blue eyes is not an illness or a condition, but it's still the way that the genetics work for recessive genes. And so for things like cystic fibrosis, for example, I might not know I carry a gene for cystic fibrosis and my husband doesn't know, but we could create a child that has cystic fibrosis. And so for some people, they will test, they'll do what's called a carrier screening, and that is to a test to see what they carry. All right. Do you carry anything that, that could be, have a lasting effect for your child? Do you carry it? Let's see what we could potentially come up with if these two people have a baby together. That's the carrier screening for recessive genes. For dominant genes are things that can pass on. The dad or the mom, they have something, they know they have it, the gene is dominant, and they have a 50% chance of producing a child that has it. So that's a difference between dominant and recessive. Okay, on dominant, I know, all right, I know that I have Marfan syndrome. And so I know I could create a child that has Marfan syndrome. That's a dominant gene. Where recessive, I don't know. So that's where carrier screening comes in, because you can test for it. And so I actually had a friend who they didn't do their carrier screening until after she was pregnant, and then found out that they both carried the gene for cystic fibrosis. And it was a whole thing. And they actually did chorionic villus sampling to see if their baby had cystic fibrosis to determine whether or not they wanted to continue the pregnancy. And then on a future pregnancy, they did IVF and used donor sperm because they didn't want to risk it. It was that important to them. So carrier screenings really help people make good decisions for themselves and their families as to if there's recessive genes, then what they could potentially create in a child. Make sense?
So for this PowerPoint, do we need to know just how the recessive genes and dominant genes are broken down? Or do we need to know that and which disease fall under either one, or just how they work?
I think it's more about how they work and how we screen for it, less about what genes are dominant, what genes are recessive.
Okay.
Yeah, I think it's just more understanding the recessive genes are things we don't know what we have, so we can screen for it. Okay, I don't think these are just examples to give you guys an example of some of the things that are affected by dominant recessive genes.
Do we have access to this PowerPoint, or just go back in recording through and like watching you go through the PowerPoint?
So it should be posted in your announcements. I can try to put it in the chat. It's kind of a big file.
Okay.
It's on
I'll
this.
check my announcements though.
The PowerPoint is on the email that the Zoom meeting came on with the schedule for the study sessions.
Got you. Okay, thank you.
You're welcome.
I'm trying to find it.
I got it out of the announcements.
Yeah, it's in the announcements for most students, but if you can't, if it hasn't been posted by your instructor yet, or you can't find it, I was going to try to put it in here. Exam 1.
I
Okay,
know
theo-
I had to email it to some of my other classmates and another one. So if someone wanted to put like their school email in the chat, I have no problem emailing it either too.
okay, I theoretically just uploaded it to the chat. So see if you see it there. Okay, I know sometimes if I try to upload a file into the chat, some people don't see it, but theoretically it's there. So see if you can grab it.
It worked for me.
Perfect. Okay.
I see it. Thank you.
You're welcome. Okay, so other types of screenings. So multiple marker screening, or it's also depending on how many things they're looking at, it might also be called a quad screen. These screenings happen after pregnancy happens. So when we were talking about carrier screenings here, this is something we could do before they're pregnant, right? To see what recessive genes they have. With our multiple marker screenings or our quad screens, the pregnancy is happening. It's currently there. And what we can do with this is we can look at levels in the blood of alpha-fetoprotein, HCG, estradiol, and inhibin. And these give us an indication if we have things like Down syndrome and neurotube defects. Okay, so alpha-fetoprotein is one of the big ones we look at. And if the alpha-fetoprotein is low, that gives us an indication that the baby may have Down syndrome. So we think about low down. Okay, if the alpha-fetoprotein level is high, then that could be an indication that the baby has a neurotube defect. Okay, so spina bifida, myelomeningocele, anencephaly, stuff like that. Okay, so that is the multiple marker screenings. So this is something we do after she's pregnant. Other tests we can do. So one of you, and I'm sorry, I don't remember which one, mentioned that we can check for that Mia said that the amniotic fluid helps with lung maturity, which is absolutely true. And I said we can also test for that. And this is how we would do it. So this is a testing that we would do for a couple reasons. And this is an amniocentesis. With an amniocentesis, we're taking amniotic fluid out and we're testing it. If we're testing it early in pregnancy, it's because we're concerned about a congenital anomaly. Maybe we did this test and we got a low alpha-fetoprotein and we're looking for Down syndrome. And this is going to look at the chromosomes and it's going to be able to tell us if we have a chromosomal abnormality, if we have a trisomy, if we have a monosomy, things like that. In late pregnancy, we can look at the amniotic fluid, and because the baby does breathe it in and out of their lungs, we can actually look for, it's called an LS ratio. And we want this ratio to be 2:1, and this gives us an indication that there's sufficient surfactant in the baby's lungs, that their lungs are mature for birth. This would be a time to do this would be like, she's less than, we expect that by 35 weeks, those lungs are mature, but maybe she's 34 weeks and she has preeclampsia and it's becoming more severe and they want to decide if they should induce labor, things like that, then we might do an amniocentesis for lung maturity. Okay, but more often I think we're doing it for congenital anomalies. What do you think could happen with an amniocentesis? What kind of risks might go with that? Infection. Water, I got water breaking in the chat. So early in pregnancy, it can cause infection. It can cause miscarriage. Okay. And later in pregnancy, it could cause preterm labor and still infection for that too, because you can see in the picture, we're putting a needle through the belly into the uterus and grabbing amniotic fluid with a syringe. Okay, so it's very invasive. Go ahead.
Water break like contraction?
You could have contractions. Yep, the water could break. Typically the needle's tiny and the bag will close back up over that spot, but it's possible that that creates a soft spot there and that the water could start leaking from there. Okay. All right. So some of the things that we are considering when if we look at the alpha-fetoprotein and we look at, or even if we're doing like an amniocentesis and we're finding chromosomal abnormalities, Our most common one is our trisomy 21. What's trisomy 21?
Down
Down
syndrome.
syndrome.
It's Down syndrome. And we probably all know somebody that has Down syndrome, and they are usually able to lead a pretty good life. They tend to have more physical problems like heart defects. There's visual things we can see. You can look at a person with Down syndrome and know they have Down syndrome, right? Because they have those almond-shaped eyes. If I see a baby that has almond-shaped eyes, I might look in their hand and check for the simian crease. So if you look at your hands, we usually have 2 lines, but your Down syndrome baby usually has 1. Their tongue is larger. They can have these little spots in their eyes called brush-filled spots. They tend to have some intellectual difficulties, things like that. But they typically do okay. It helps parents, I think, to know if they're going to deliver a baby with Down syndrome, so they can mentally prepare for the fact that I think that any parent, when they're expecting a child, they're expecting a perfect child, and their mind might not think this is perfect. Okay. Other trisomies that are more common ones are usually, the babies don't usually survive long. Trisomy 18 is Edwards syndrome, and trisomy 13 is Patos syndrome. I've had a few patients whose babies had trisomy 18s, and they delivered, and the baby didn't live very long. And there's a lot of comfort care that goes with that, which we talk about in our classes more at the end of the term. Okay, so these are common trisomies. What do you think a trisomy is? You guys remember?
Where there's 3 chromosomes instead of just a pair.
Okay, yep. So we should have 46 total, and with the trisomy we have 47, because on the 21st we get 3 instead of 2, or on the 18 or whatever. Okay. So for neural tube defects have to do with, I mentioned spina bifida, myelomeningocele, and anencephaly, and these are examples of that. And so this is when we might see this when the alpha fetoprotein level is high. It might be an indication of this. And so the neural tube goes from the brain down the spinal cord. And if it doesn't develop properly, these are the things that can happen. So this spina bifida and this myelomeningocele causes an outpouching here. And depending on the severity, sometimes this can be fixed, sometimes it can't. I mean, they can cover it, but sometimes this person isn't really able to walk. So what is our number one big thing? I don't see them on my screen anymore. The number one big thing that somebody told us early on that we should have moms do before they get pregnant to help prevent this.
Take folic acid.
Take folic acid. Okay, taking folic acid before conception is going to greatly reduce the risk of neural tube defects. All right. Moving on to Nagel's rule. Does everybody feel comfortable with Nagel's rule?
Yes.
All right. Client arrives at a prenatal clinic for the first prenatal assessment. The client tells the nurse that the first day of her last menstrual period was September 19th, 2013. Using Nagel's rule, the nurse determines the estimated date of confinement, or the due date, is what?
See?
C.
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 So I have some B's and I have some C's. So let's go back and entertain this slide for a minute. Okay, what are we doing? We're gonna take the day of the first day of last menstrual period. Which way are we going for the month? Forward or back?
Back 3 months.
Back 3 months. So this said September. So let's go back from September. So August, July, June, right? Okay. So we go back 3 months and now we're gonna, what are we gonna do with our days?
Add
At 7.
Add
Add
7. So our date was the 19th. So 20, 21, 22, 23, 24, 25, 26. So June 26th.
Next year.
We were on 2013. We're going to add a year. So we're at 2014. So C is the answer. Okay. Good job. All right. Gravidity and parity. What do these terms mean?
Number of pregnancies.
Okay. Number of pregnancies. Does it matter what the outcome was?
No.
No.
Good.
Figured that out last night.
Okay. So gravidity is our number of pregnancies. What is parity?
Your term and preterm pregnancies.
Combination of term and preterm deliveries.
That's what I meant. I'm sorry.
Yep. I figured. All right. So this is when she's completed the pregnancy. All right. Term and preterm. So how do I know if she's term or preterm?
With negligible,
37.
37. What happens if she's less than 20?
an abortion, she doesn't make her baby.
Okay. So it's not going to count in parity if it's less than 20. Okay. So term and preterm is going to be greater than 20. Preterm is greater than 20, less than 37, and then term is 37 and above. So
I thought it.
go ahead.
So, can you say that again? Term is. Say that
It's
again.
37 weeks and up.
Oh, yes.
Okay. So 37, 38, 39, 40, 41, 42 is all term. Okay. A 28-year-old woman just delivered at term. She has a 3-year-old daughter who's delivered a week past her due date. And last year she had a miscarriage at 8 weeks gestation. How would you note this history using GTPAL?
28-year-old woman delivered at time. She has a 3-year-old daughter who was delivered a week past her due date. And last year she had a miscarriage at 8 weeks. So 2, 1, 1.
Well, she's coming in pregnant, so the G would be 3, right?
Good. Yep. She
And
came
then-
in pregnant or
Okay.
delivered. She just says she just delivered, has a 3-year-old, had a miscarriage. Okay.
So 3.
And 2 are delivered at term.
Okay.
We need to see.
Okay. I'm gonna
He
grab.
always
I'm gonna
throws
grab my
me
board.
off.
Hold
Would
on.
it be 3? Would it be 31101?
I think though she just delivered a term and she had a post date, so that one counts as term also. So it should be 3-2.
Yeah, 32. I'm sorry.
And then she doesn't have any preterm deliveries. 0.
The A would be 1.
And
A
then
is 1.
the L
And
is
then-
2.
And the L is 2. Okay, I'm gonna grab my whiteboard. Hold on. I just forgot to grab it before I sat down. All right, so then let's do the second one. So that one was right. So this one says your prima gravida patient comes for her 40-week prenatal visit. How would you know her obstetric history?
G1.
Well, yeah, it says prima gravida. What does that mean?
It's her first pregnancy.
It's her first pregnancy. And she's there for her 40-week prenatal visit. So what's the rest of it?
Already to term, but she's not delivered yet.
Right.
So she's 0 everything.
She's 0 everything.
Oh,
Wait, what just happened?
Oh, I didn't realize those were two different questions. I thought, okay.
Yeah.
I was
it's
using
two
them both
separate-
as one person.
Oh, yeah, no, it's separate. So what the second part, it starts with your prima gravida patient comes for her 40-week prenatal visit. So she's a prima gravida. Prima means first pregnancy. And so she hasn't had any deliveries yet. So the rest is zeros. Now, let's say she delivers. How does it change?
G1, P1, and everything else would be preterm would be 0, abortions would be 0, and living children would be 1.
Is she term or preterm?
Term.
Okay. I thought that's what you said, but you were so speedy. I was just making sure. What is, okay, so now she's a G1, T1, P0, A0, L1. So is she a prima gravida or nulla gravida or multigravida?
Prima gravida.
Prima gravida. Is she a prima para, nulla para, multipara?
Prima para.
Prima para. What if your patient came in, let's say, hold on. Let me look at the first girl. Let's go back to the first girl for a second. The first one was, she delivered at term. Oh, she's already delivered. Let's say she's still pregnant. She is pregnant at 40 weeks. She has a 3-year-old daughter and had a miscarriage. Let's say she's still pregnant. What's her G again?
3.
3. And if her baby, if she didn't just deliver this term one, what would be her TP?
Well,
TPAL.
what is she at week-wise if she's still pregnant?
It says she's term, so let's say she's 40 weeks. She just hasn't delivered yet,
Term is 2.
but she hasn't delivered yet. So we're
Oh,
not going to count. We're not going to count the pregnancy here in parity because that baby's still in the belly. Okay.
So T would still be 1 then, because even though we know she's term, she's not born yet.
Exactly.
Okay.
Does that make sense? I can't count it as a T or a P until the baby's out. She has to complete the pregnancy for it to count in her parity. All right. And so then we said 0, we said 1, and now she has 1 living because she hasn't delivered that other baby yet. And the reason I wanted to do this is because I just want to ask you, is she a nulla gravida, prima gravida, or multigravida?
Multigravida.
She's a multigravida. She's had more than 1 pregnancy. Is she a nulla para, prima para, or multipara?
Multipara.
Prima.
She's a prima para. She's only delivered 1.
No.
and
Okay.
you said no.
What's that?
I'm just reminding, no, right?
Null is none.
Yes. Okay.
Prima is 1.
Multi is many.
And then multi is more than 1. It helps if I spell right. Okay. So this is 0, this is 1, and this is greater than 1. So this patient, before she delivers this second baby, she's a prima para. And then once she delivers the second baby, then this goes up to a 2 and she's a multipara. Okay.
On the multigravida on the PowerPoint, it says had 2 or more. Is it 2 or more or just 1 or more?
Well, no. So for a multi, it is going to be more than 1, which is 2 or more. All right. Multiple is more than 1. So
Okay, yeah.
it just, instead of it saying instead of it says had more than 1, it says has had 2 or more, but they both mean the same thing. Okay. Does this one have twins in it? Nah, I don't think we need to do that one. All right, so here's the matching. So let's do this one. We're gonna say number 1, 2, 3, 4, 5, 6. So number 1, an adolescent pregnant for the first time. Which term does she get?
Prima
Prima
gravida.
gravida.
Prima gravida, pregnant for the first time. So that's C. G2T0P1A1L1.
Multigravida,
She would be multigravida.
but she's
We might need it for another spot. We'll put it there for now. Because she has had more than one pregnancy. Wait, yeah, she has had more than one pregnancy, so she could be
But
considered
she could be a
multigravida.
prima para as well.
She could be a prima para as well. So she could be A. She could be, where is it at? B? Right? No,
I'm
that's
sorry.
multipara.
E.
E.
I'm sorry. I think you said what prima para. Can you tell me what that is again? I'm sorry.
Yeah, well, that's why we're doing this. All right, so prima means 1. Let's go back to this. Okay, so with a prima para, she has completed 1 pregnancy with a fetus greater than 20 weeks gestation. So what that means is she has delivered a baby that wasn't considered an abortion. It was more than 20 weeks. Whether term or preterm doesn't matter. Prima means 1. And so when we go back to what this thing said here, G2 means she's a multigravida. She's been pregnant more than once. And then the T and the P, I can't make my mouse work. T and P, these two together, it's term and preterm, they combine to make the parity. Okay, so between term and preterm deliveries, she's delivered 1. And that makes her a prima para because she's had 1 delivery greater than 20 weeks. She has an A1, which means she's also had a delivery less than 20 weeks. And then she has an L1, and that is that preterm birth there. So when we're looking at the terminology on the right, she is a multigravida because she's had more than 1 pregnancy. And she is a prima para because she's delivered 1 baby. Does that make sense?
Yes. So for testing purposes, we wouldn't put both of them. It would definitely be E.
Well, for testing purposes, it wouldn't be set up in a way that you could do both. This
Okay.
is just a way for us to discuss it and make sure you understand it. It's just a matching game.
Okay, thanks.
Yep. All right, 26-year-old with 1 abortion and a 38-week delivery. What do you think about her?
That'd be prima para.
She's a prima para. She's had 1 delivery.
she's
What
also
else?
multigravida.
Yep, prima gravida, right? Nope, multigravida. My bad. Hold on. I wrote the wrong one. Right? She's had a pregnancy that ended in an abortion. She's had a pregnancy that ended in a 38-week delivery. So she is a multigravida. She is a prima para because she delivered that 38-weeker. Is there anything else? I think that's it. Okay, number 4, 34-year-old who has never been pregnant.
A nulligravida.
Nulligravida. And so none of the other things will apply to her. She's never been pregnant. 24-year-old with 3 abortions.
Multigravida.
Oh yeah.
Multigravida.
The multigravida. Is she anything on the parity?
Would that make her a nola gravida or no?
Well, she could be a nullipara because
nullipara.
which isn't a choice on our list, but she hasn't completed a pregnancy over 20 weeks. So she is a multigravida. And but nullipera is not a choice, but she could be a nullipera. Okay. 28-year-old with 2 children.
Multigravida and multipara.
Multipara.
Okay. And where's it at? B. Okay. Does this make sense, guys?
Yes.
Good. All right, so we're going to move on to our signs of pregnancy and our changes that happen in pregnancy. Okay, probable signs, positive signs. So how do I know which signs are which? What are presumptive signs?
Objective signs.
Something the patient reports.
Good, it's subjective. It's something the patient tells you. All right, presumptive has an S in it to help us remember it's subjective. So these are things your patient tells you. So what are some examples?
Oh, I'm throwing up.
Good.
My period hasn't come.
My period hasn't come. Okay, what else?
Breast tenderness,
Yep.
fluttering, or quickening feeling.
Quickening. Okay, so why is quickening not a probable sign of pregnancy?
Because couldn't it be due to something else?
Yep. Good.
Yes.
What is quickening?
What is quickening? Who knows?
It's when mom kind of has that, like, I think the book described it as like a little butterfly feeling in her stomach. So kind of that first fetal movement that mom feels a baby.
Exactly. Exactly. So, but it counts as subjective because she's telling you, I felt the baby move. Well, she might be feeling quickening. She also might be having gas. Okay. So you laugh, but it's true. So it's a subjective finding. All right, good. So what are some probable signs of pregnancy? What does probable mean?
What you observe. Objective.
It's objective. Okay. And so these are things that you can assess. All right. And so what are some examples?
Soft serving.
Mm-hmm.
Positive pregnancy test.
Positive pregnancy test. If we do it at the facility, then that is a probable sign. If she peed on a stick at home and said, I had a positive pregnancy test, that's not going to count. But for the most part, if you see positive pregnancy test, we're assuming you tested her. So it counts as objective or probable. Okay, what else?
The Chadwick sign.
Chadwick. What's Chadwick?
It's when the
Blue.
cervix and whatnot, the vagina and vulva have that bluish tinge to it.
Discoloration.
Okay, good. Good. All right. What other things could be probable signs?
Braxton Hicks contractions.
Braxton Hicks contractions. What's that?
Basically unproductive contractions.
Yeah.
Okay, how come that's a probable sign?
Because you can measure those.
Good. You can measure it. It's measurable. I can put a toco on her and see them. I can see that the uterus tightens. I can palpate it. I can put my hands on her belly and feel the uterus getting tight. So I can assess it. Okay, it's measurable. Good. So it's probable sign of pregnancy. What are positive signs?
Is it the one where you feel the fetus heartbeat?
Good.
Something the baby
The movement.
can only present.
Okay, so things that come from the baby. All right. Now, fetal movement that we can assess can be a positive sign. And so quickening that the patient feels is presumptive. But if I assess it, if I see it on ultrasound, if I feel it with my hands, that it's definitely coming from baby. Usually we see it on ultrasound, then it can count as positive. Okay. So the patient usually feels fetal movement around 16 to 20 weeks. I need to be able to see it and assess it to count it. All right. But if it comes from the baby, if I see it on ultrasound, I hear the heartbeat on the Doppler, or I can see the baby on ultrasound, those are positive signs. There's a baby for sure. I saw it. Okay. So things that are happening to mom's body during pregnancy. What do you think?
Her breasts get larger.
Okay. Breasts get larger. And that's that estrogen, right? Estrogen enlarges. Estrogen makes her breasts grow. What else?
She has her back pain.
Back pain.
What is it called? Sorry, the word is not coming out.
Are you
Lordosis?
thinking of lordosis?
Yes, yes.
Yeah. So there's a few things that happen with back pain. Later in pregnancy, they develop lordosis, where they their center of gravity has changed. And so they're kind of needing to alter the way they stand, and their back becomes more of a sway back to try to carry all this weight that's in the front. And that can cause back pain. Early in pregnancy, all of the progesterone that is released and happening in the body causes the connective tissue in her back to relax, and that can also cause her to have some back pain as well. Okay. For patients that are having back pain, especially early in pregnancy, we can encourage them to do a few things. All right. What am I thinking of? The belly band, where there's kind of a thing that they can wear around their back and belly to help support, and that can help with their back pain. We can encourage them to do pelvic rocking, and that will help strengthen that connective tissue, and that can help with their back pain. The other thing that can happen too is that because that their body is, the connective tissue and the pelvic joints are relaxing to make room for the baby, they can also kind of waddle. And that's also another thing that we see with the progesterone that is contributing to that. Okay, so all this stuff goes with back pain, lots of stuff that cause back pain, and the things they can do for it. What else?
They have different cravings, like chalk.
Oh, what is that called?
Once again, I can't think of the word.
Okay. Somebody help her out. She says they have different cravings, like they can crave things like chalk. What is she thinking of?
Is that the one that starts like with a P?
Mm-hmm. Yep.
I want to say petechia, but I know that's not it.
Nope. Yeah, it's pica.
There we go.
Yep. And what causes that? Do you know? Anybody know? We're going to talk about it on our nutrition slide. All right. So musculoskeletal, we have back pain. Also leg cramps. If they get leg cramps, what's the best way to relieve that? Do you think?
Dorsiflex the foot.
Yeah.
And I saw it on my NCLEX, one of the questions. I can't remember if it was extend the knee.
Yeah, you can
or-
extend the knee and dorsiflex the foot.
Okay.
The thing is when that muscle spasms so bad, they want to point their toe and it makes it like that knot tighter. So they need to dorsiflex to stretch and pull it out, which hurts. It's so hard to do, but that's going to cause the muscle to relax. They can try to step on it, but it's really painful in that moment. But that's also going to dorsiflex the foot. But flexing the foot is going to cause that cramp to release. Okay. So those are our musculoskeletal things. What about on their skin? Changes in their skin?
Stretch marks.
Stretch marks? What else?
Their breasts get their breasts get this color, like color change, the nipple change, color in the nipple.
Absolutely. Absolutely. So the areola becomes darker. Good. Yep. What else?
They get constipated.
They can become constipated. All right. We've got less GI motility. So they can become constipated. They can also have increased heartburn, nausea, vomiting, stuff like that as the GI part. What do you think women that are constipated should do in pregnancy? What will help with that?
Fluid.
Fiber.
Fluids and
Right.
fiber. Ambulation, get up and move around. Okay, those will all help with constipation. Some women even need to take like Colace to keep their bowels moving because we give them prenatal vitamins, and prenatal vitamins are high in iron. And what does iron cause?
Discoloration of poop.
It could cause discoloration and poop, but it also causes constipation.
Patients,
So
yes.
yeah, absolutely. Okay. Other skin ones that I was thinking of is chloasma. Or also called melasma, and it's where their face can have a discoloration on their cheeks and their nose. Linea nigra, the dark line up their belly. And then we covered the gastrointestinal stuff. Renal, they pee more. They're also hypercoagulable. All right, so they produce clots easier. So we don't want them to sit for long periods of time. All right, so if they are working in a place where they're, on their computer all day or something like that, then they should be moving their ankles around and stretching their legs out and keeping that blood flowing through their calves so they don't get a blood clot. Okay, so progesterone contributes to a lot of these things. So when we are talking about the relaxed pelvic joints, the connective tissue, things that cause their back pain, things that contribute to the skin discolorations, all of these are fed by progesterone, but progesterone is also going to maintain the pregnancy and keep them pregnant, and those are produced by the placenta. Okay. Any other thoughts, ideas there's so many things. Like this is just a touch of it. There's so many changes that are happening in pregnancy. The client who thinks she is pregnant comes to prenatal clinic to begin care. Which data provides the most definitive confirmation of her pregnancy?
Four.
Yeah, we heard the fetal heart tones. She's definitely pregnant. Positive sign. All right, so now for our prenatal care. So in our first prenatal visit, we checked the alpha fetoprotein. We did a carrier screening if they wanted to do that, if they hadn't done it already. We are going to, in that first appointment, really develop a rapport with our patient, right? We need to make sure that when you meet with your patient that they are communicating with you some of the things they don't really want to share with people, like if they're using drugs and things like that. I need to know those things so I can best take care of her. All right. We're going to do blood work on that first appointment. What blood work do I want to know?
HIV.
Okay, HIV.
Vaccines.
Okay. What else?
CBC.
What's that?
Complete blood count.
Okay, CBC, complete blood count. Why do I want to know what the CBC is?
So you'll have something to compare it to later.
Yeah. Okay. I can compare it. I also can determine if she's anemic. All right, because she might need to take more iron if she's anemic. Okay, so for both of those reasons, that's helpful. Why do I want to know about HIV?
But she's going to need like prophylactics to make sure she doesn't pass it on. That and other standard precautions when dealing with an HIV patient.
Absolutely. So we give them an antiretroviral through the whole pregnancy to help minimize the risk that she passes it to baby. And then, like Anna said, also precaution wise. Okay. What else do I want to know on her initial blood work?
Her HbG1.
A CMP.
Okay, we can do a CMP. What I missed what somebody said right before Katie with the CMP. Okay, we're thinking about, I need to know what her blood type is.
A typing screen.
Yep. So we're gonna check her blood type and see if she's Rh positive or Rh negative. Okay, because if she's Rh negative, there's things we're gonna do for that mom that's different than if she was Rh positive. Okay, so we're looking at Rh incompatibility. I don't know what the baby's blood type is, but if mom's blood type is Rh negative, then there is the potential for a baby to be positive, and then I have that incompatibility. And so I want to know from the very beginning of pregnancy, because at around 28 weeks gestation, she's going to get RhoGAM, and then after delivery, we'll test the baby. And if the baby's Rh positive, she gets RhoGAM again. Anybody have any idea what I'm talking about with this? What is that, RhoGAM and Rh negative and all that? What's the concern here?
Isn't that because if the the mother's Rh positive and babies, or excuse me, if mother's Rh negative and babies Rh positive, then the mother's immune system will attack that baby because of the incompatibility, and that could, obviously cause problems for baby.
Okay, absolutely. And so the RhoGAM, the idea of giving RhoGAM keeps mom's body from building up those antibodies that would attack the baby. So we give RhoGAM at 28 weeks gestation, and then we'll give it after the baby's born. If we test the baby and find that the baby's blood type is positive. If baby's blood type's negative, then it doesn't matter. Also true if she miscarries. If her Rh is negative and she has a miscarriage, she should get RhoGAM, because that the antibodies will build up and will attack the next baby. Okay, so that's what we're thinking about with if the Rh is positive or negative. Does that make sense to everybody?
Yep.
Makes sense to Anna.
But
She was the
that
one
is
that
only when the mom is Rh negative, right?
correct. Yep, if mom is Rh negative, that's the concern. Okay, if mom is Rh is positive, then there's not a risk. Baby can be positive or negative and it's fine if mom's Rh is positive. But when mom's Rh is negative, that's when we can have this problem. Okay, so other things we're thinking about at that first appointment. We're thinking about, rubella. Let's talk about rubella, because it's one we haven't touched on yet. I want to know if her rubella if she's immune to rubella. That's something we test for at the first appointment also. If she's not, so the concern with rubella is that it can have a very detrimental effect in pregnancy. If she contracts rubella, it can cause problems for the baby, especially hearing loss. But if I test her and her rubella is non-immune, then can I go ahead and vaccinate her while she's here?
No,
No, why?
it's a live virus vaccine.
It's a live virus vaccine. If I give it to her, then I can create the problems for baby that we're trying to avoid. Okay, so I want to know if she's immune or not, but I'm not going to treat it till after she delivers. And because it's a live virus vaccine, we can vaccinate her after the baby's born, and then we're going to want her to not get pregnant for at least a month after for the same reason, not get pregnant again. Okay, if she is getting preconception care and we find her rubella is non-immune, we could treat it if she waits to get pregnant for at least a month, but we're not going to treat it in pregnancy. We're going to find out how much she weighs, and we're going to find out what her blood pressure is. And these are going to give us a baseline. Okay. Her blood pressure at the beginning of pregnancy shouldn't be high. If her blood pressure is high, then she probably has chronic hypertension. Okay, and that's a good thing to know. If she has chronic hypertension, that's one of the things that can cause things like growth restriction or IUGR. Okay, we're assessing the other things that can be detrimental to her pregnancy, like lifestyle choices. Do you smoke? Do you do drugs? Stuff like that. And then we usually do an ultrasound on that first appointment. Depending on how far along she is, sometimes it's a transvaginal ultrasound so we can see this tiny little embryo. If she's further along in her pregnancy, we might just go straight to a transabdominal ultrasound. And that's also what we do later as the pregnancy progresses. If we're going to do ultrasound, it helps if her bladder's full because it's going to lift the uterus up out of the pelvic cavity so we can see better. And we use ultrasound for all sorts of things. Okay, it's non-invasive. It's we can look at her fluid level. We can look at how the baby's growing. We can estimate her due date way more accurately than using Nagel's rule. Okay, by doing ultrasound. And so after we do this on our first visit, then on our subsequent visits, a lot of this stuff we're reassessing. Well, and also not included on here, but also needing to do every appointment. What should we be asking every appointment? What do you think?
Someone pay for emptying bladder.
I'm sorry, say it again, Mia.
I said someone work on the chat for transvaginal.
Yeah, I
Do you
see that
think
in the chat. Yep. And I'll address that in a second. What questions should we be asking at every appointment though?
You should be screening for abuse.
Yep. Abuse, intimate partner violence, abuse, depression, every time. The question in the chat has to do with the ultrasound. If I'm doing a transvaginal ultrasound versus the transabdominal, and Courtney brings up a good point here. If we're doing the transvaginal ultrasound, we're putting a probe in the vagina, it is going to be better for that bladder to be empty. Okay, and then if we're doing a transabdominal ultrasound, it's better for that bladder to be full.
Is that
kind of
unless
like
it's setting the baby up too far? Unless
Okay.
it's distended, like the placenta is distended or something?
I figured it was kind of like a pelvic exam. You don't want that pressure in you while you're having a full bladder.
Yep. Yep. And Katie, ask again what you said because I missed part of your question.
So whenever you're doing the exams, whenever you're feeling where the baby is, if you feel it maybe being too high or displaced or something, then do you have them empty the bladder?
You can. So a really full bladder can contribute, like you're thinking later, right? You're thinking
Yes.
about like when she's in labor.
Right.
Yeah. I typically in labor have them empty their bladder before I check their cervix anyway, just because it's kinder. It is possible that a full bladder can I'm much more worried about a full bladder after the baby's born and it displacing the uterus and causing the uterus not to contract well and bleed. And we're going to talk about that as week 4 stuff. When she's actually in labor, the contractions are kind of pushing down on that. So we're probably not seeing as much of a displacement, but theoretically it could.
Okay.
Yeah. Okay, so we're screening for intimate partner violence at every appointment. And at every appointment, we're going to check her weight. We're going to check her vital signs. I have urine on the slide, and historically, they check the urine all the time. I'm hearing from patients that we're not doing that at every appointment anymore, but I don't know. I can't verify that. When we were doing urine assessment every appointment, we were looking for protein. So they would dip the urine for protein. And that's because that protein in the urine is a good indicator of what, do you think? Any idea?
Diabetes.
Preeclampsia.
Preeclampsia. Yeah. And we'll learn about that somewhere in a different week. But we can also screen the urine regularly for infections. Some women can have UTIs and not realize it. And so if they have asymptomatic bacteria, then that can create a problem for them. But that's not something we're necessarily doing routinely. But I want to know what her weight is. Do you guys know the normal weight gain?
Is it 25 or 15 or 25?
25 to 35.
25 to 35 is going to be our normal weight gain. And how much of that do you think she gains in the first trimester? Any idea?
Is it like 8 pounds?
Not even. It's so low. The first trimester, all of our organ systems are developing, but we're not getting a lot of growth yet. And so the baby's growing a little bit, but the baby doesn't weigh hardly anything. And then we have a little bit of an increase in fluid and things like that, but it's not a lot. So in that first trimester, she's really only gaining between like 1 and 4 pounds. Once we get to the end of the first trimester, which is the first 12 weeks, now we start seeing her gain about 0.5 pound to 1 pound a week. And I want to assess that at every appointment, because if we have an unusual amount of weight gain, that can be an indication of things like if we have a baby that's growing too big, macrosomia. It can be an indication of things like preeclampsia, if she's holding on to a lot of fluid in her body. If she's not gaining enough weight, that can give us an indication that we have an intrauterine growth restriction, where the baby's little, poor nutrition, things like that. So we're checking weight every appointment. We're checking vital signs every appointment, especially that blood pressure. We're watching to make sure that it's staying normal and it's not becoming elevated. Fetal assessment. What kind of things might I do for a fetal assessment at her prenatal appointments?
Heart rate.
Say that again.
You would check the heart rate?
Okay. So we can Doppler and listen to baby's heartbeat. Okay, and that's the main thing we do. We'll also ask patients if they're feeling, once they're over 20 weeks, are they feeling their baby move? And we teach them to do kick counts, where we have them time the kicks for an hour, and they should feel 10 movements in an hour. And then we're doing fundal height. Fundal height is going to give us a good indication of how our baby's growing. Who knows how we measure fundal height?
That's what I meant. That's the exam I was talking about. I could not think about that.
Oh, okay. Perfect. So how do I measure and a full bladder can potentially affect our fundal height a little bit. That's what you were thinking about as far as
Yes.
the bladder. Yep.
No,
So the things that can affect our fundal height, full bladder can affect it a little bit. Also, when the baby drops, who remembers the term for when the baby drops?
Lightning, right?
Lightning. Good. When the baby drops, that's going to affect our fundal height too, because now the head's more engaged in the pelvis. So there's a few things that can affect the fundal height, but for the most part, when we're measuring fundal height, what do we anticipate? What do we expect to find?
I mean, growth,
Soft.
right?
You want it to be soft.
Okay.
You don't expect it to be off to one side or the other for the most part.
Okay, it should be midline.
You don't.
It's a measurement, right? So we're going from the pubic symphysis up to the top of the uterus. And what number should we see? Do you think?
A matching number to the week.
Good. Okay. So when we do our measurement, the number of centimeters from the pubic symphysis to the top of the fundus should be within 2 plus or minus of the gestational week. All right. So like if I'm measuring, I will anticipate finding the fundus pretty close to the belly button around the 20th week. And on our strip, our measure tape, that's going to be right around 20 centimeters and so on, okay, as it gets bigger. So the numbers should coincide. Early in pregnancy, I'm going to expect, I'm not even going to be able to find a fundus in the first 8 weeks, right? And so as now the uterus is starting to grow, then it'll go up. So it's between the pubic symphysis and the belly button, and then higher. So the belly button is kind of my 20-week landmark, but we're going to measure, and the centimeters should coincide with the gestational week. This is one of those times that she could have supine hypotension, right? I have her on her back to do my measurement. So she might feel like garbage and I might need her to turn on her side. If she feels bad because of supine hypotension, how am I perfusing my baby?
Not
Like
well.
poorly.
Not well. Okay, so we're going to do assessments that put her on her back kind of quickly. Measure it, get her off her back. So that's our fetal assessment and our fundal height. We're providing education at each appointment. Education about breastfeeding, Kegel exercises. What do Kegel exercises do?
They strengthen the pelvic floor.
Good. Strengthen the pelvic floor. So this is helpful for before pregnancy, and it's going to be helpful after the baby's born too, to strengthen the pelvic floor for both for labor and after birth. We're teaching her about nutrition. I have a whole slide on nutrition in a minute. Hygiene, oral health, and exercise. What kind of exercises should pregnant ladies do?
Water aerobic exercises.
Good. Okay. Aerobic, water exercises are good. What else?
I mean, as tolerated and per the providers, letting them, like, saying they could still do it. I mean, anything they were able to do before, still before, because I know, like, lately with weightlifting and stuff like that, you could still do it, but obviously still get checked, doing things safely that you were able to handle before. Don't do anything crazy.
Don't do anything crazy. We're going to encourage them to kind of focus on low impact. So weightlifting might be okay because it's kind of low impact, right? I had one that rode horses. I had one that ran marathons. Those are the exceptions. Usually they're encouraged not to do those things. They're encouraged to stick with low impact. So things like swimming and yoga and walking and things like that. Okay, low impact is going to be better. And then we're educating moms for potential problems. All right, if she has any vaginal bleeding, she should report that. What might be happening if she is having vaginal bleeding?
Sometimes a miscarriage.
Yeah, could be a miscarriage. Heartburn. If she has heartburn and a headache, these two together is a big red flag for me for preeclampsia. Okay, so this is something we'd have her report. If she's leaking fluid, all right, we shouldn't be leaking amniotic fluid if her baby's not moving. So after 20 weeks, she should be able to feel those good fetal movements. And if she notices that there's a change in the way her baby's moving, or she's not feeling fetal movement at all, she should report it.
You said what with, oh wait, right there, heartburn, never mind.
Heartburn. Yeah. So we're going to learn a lot more about preeclampsia later. Like it's a huge part of, I think, week 5. But the thing with preeclampsia is that one of the things we see is right upper quadrant pain. And that can also become epigastric pain and cause a lot of heartburn sensation. And so, and another classic symptom of preeclampsia is this severe headache that is just not relieved with Tylenol. So if I have a patient that's heartburn and severe headache, I want to check her blood pressure because that's going to be the very first indicator that can let me know if she's preeclamptic. So that's one of our things on our list. And the little picture on the slide has other things, right? So we have cramping and contractions, water breaking, absence of fetal movement, the things we just discussed. Epigastric, abdominal and uterine pain, muscle irritability, spotting or vaginal bleeding, urinary frequency, or oliguria. So those are signs of UTI, and persistent vomiting because she could get dehydrated. So those are all, this is the acronym CRAMPS UP. Okay, so all danger signs to report. Pregnant woman is at 32 weeks gestation and complains of feeling dizzy and lightheaded while she checks her fundus. We've talked about this. She's dizzy, she's lightheaded, she's having her fundal height checked, her skin is pink or pale and moist? What's going on with her?
D.
Yeah, turn her to her side. Why does she feel like that?
She's having orthosteric hypotension.
Hypertension.
Yeah, good. Supine hypotension. She's on her back. All right. So we already talked about weight gain. We've talked a lot about most of the things on this slide. All right. So weight gain. The other thing that weight gain gives us a really good picture of is their nutrition status. So not only how's our baby growing, but is she getting enough to eat? Okay. Lots of things that are going to be important for moms when they're pregnant is with their intake. We're thinking about them having enough DHA to help their baby's brain, the folic acid we talked about, especially before she gets pregnant. Iron we touched on for constipation. What are some things that we want to teach our patients when they're taking iron?
It's good to take it with orange juice.
Okay. Should she not take it with?
Calcium foods.
Calcium foods or her Tums.
Or coffee.
Coffee, tea, stuff like that. Okay. And then one of you said earlier, we would teach also that it can cause dark stools. It contributes to constipation. So remembering our fluids and our fruits and veggies and ambulation and all that. Our complex carbohydrates are going to be the best way to get their nutrients. Okay, complex carbs have their vitamins, minerals, and fiber. Yeah. Oh, so our patients that have, so most of the time, guys, we can educate patients adequately about their nutrition, but there's going to be a time, certain conditions and certain times when a dietitian is a better choice. And so one of those times is going to be with patients that have food preferences. And I don't mean like, I don't like to eat chicken. I mean like, I'm a vegetarian. Because, for example, vegetarians lack B12. Okay, because where do we find B12?
In red products.
In meat. Okay, so they lack B12, which can be a detriment to the way they grow their babies. So a dietitian would be appropriate for that patient. A dietitian is important for your adolescent because your adolescents, not only do they have a higher prevalence of iron deficiency, but they have a higher incidence of IUGR. What is IUGR? What do you think? I've said it a couple times today, and then I've qualified it by adding what it is, but I want you to know what it is. If you see IUGR, intrauterine
growth restriction.
Yeah.
I didn't know if that was right.
Growth restriction. Yeah. IUGR is intrauterine growth, inside, uterine, the uterus, growth restriction. The baby's not growing well. Okay. And there's a lot of things that can cause IUGR. Some of them are those comorbidities we talked about before, right? Like hypertension can contribute to IUGR because it influences the perfusion to the placenta. Lifestyle choices that can interfere with the perfusion to the placenta, like smoking. What does smoking do to the body?
It causes buildup in things like stenosis.
Okay. And
it decreases perfusion and circulation.
It decreases perfusion and circulation because it causes a chronic vasoconstriction. So those babies, if you ever looked at a pack of cigarettes, I haven't in a long time, but the Surgeon General warning on the side, at least used to say, can cause and low birth weight. And that's because of the vasoconstriction, the chronic vasoconstriction causes IUGR. So that can contribute. Being an adolescent affects the way they grow their baby. Their body is still using nutrients for their own growth, and it affects the way that they grow their baby. So those babies also have higher risk of IUGR. Okay. Other types of patients that should have a dietitian working with them are going to be people like diabetics. All right, because when we learn about diabetes in week 5, we're going to talk more about the fact that the body uses glucose to grow a baby, and so it keeps the glucose. It's glucose sparing. And so for your diabetic, then their insulin needs go up because their body's hanging on to so much glucose. So having a dietitian involved with them to help maintain a steady glucose level will be important. Having a dietitian involved if they are obese is important. Okay, so there's a lot of different reasons why we would need to look at their nutrition in a different way. Okay, is my signal getting wonky?
It's not on my end.
Okay, good. My screen did a glitchy thing, and I'm still learning what areas of my house has a good signal and what area maybe doesn't. So let me know.
I notice it's just adjusting to light on my end.
What's that?
It looks like it's just adjusting the light on my end.
Okay, well, let me know. All right, so those are all things we're thinking about for diet. Now here's pica. So we talked about this a little bit before about women that are craving non-nutritional food or I'm sorry, that's not even usually food. It's non-food substances like chalk. I think maybe Mia brought it up. Excuse me, and that's another sign of iron deficiency anemia. And so for patients that are craving things like chalk, dirt, clay, things like that, we need to assess how much they're eating of it, like how severe is the problem, and we need to let the provider know so that we can do a blood test to find out if they're anemic. Okay. Anybody that's ever had pica before that have been compliant with taking their iron, because I've asked this question numerous times in class and friends and things like that. Some of them are like, I didn't take the iron because it made me constipated. It made me nauseous, whatever. Did find that their cravings went away because it's usually caused by a deficiency in iron. So for our patients that have heartburn and nausea and vomiting in pregnancy, what kind of things can we teach them? What should they do?
Keep crackers next to their bed.
Good idea. Okay. So having some carbs, we want to like dry carbs and avoiding the empty stomach is helpful. All right. So crackers, Cheerios, something like that they can eat before they even get up in the morning. What else?
For heartburn, avoid spicy meals.
Okay, good. Avoid spicy meals. Let's have them eat small amounts frequently instead of big, huge meals less often. Okay. All right. All right, so now when we start thinking about our high-risk pregnancies and how we assess some of the stuff we talked about already, like our daily kick counts, there's a lot of factors that can contribute to a high-risk pregnancy. So that again is our 3 big offenders, right? Hypertension, diabetes, and obesity. Also smoking, which we already talked about, alcohol intake. All right. And then patients that have sociodemographic factors. So at the beginning of today, when we were talking about the importance of prenatal care, I had mentioned the morbidity and mortality rate is higher for those that lack access to care. And so a lot of times those are going to be your low income families, but not always. Sometimes they just don't know. So it's not just always a lack of access, it might be a lack of knowledge, things like that. So all of these factors can contribute to a high-risk pregnancy. Genetics, all that stuff we talked about earlier with our trisomies and recessive genes, and all those things can contribute to a high-risk pregnancy also. So once we have a pregnancy that is considered high risk, there's a few things that we're doing on a regular basis to evaluate how that baby's growing and how that baby's doing. Ultrasound is a good tool to check the growth. Okay. Doing the daily kick counts is a great tool for patients like diabetics that are high risk. We have them do daily kick counts and report back because it's a great tool to help us assess how their baby's doing. If I have any concerns about a baby, biophysical profile, BPP, is a really great tool. What we do with this is we do an ultrasound. And in the ultrasound, we're looking for these factors that are on the slide. Okay, so remember that the baby breathes amniotic fluid in and out. We look for that. We look to see that the diaphragm move. We look to see the baby's fetal movements, the muscle tone. Then the other factors we look for is what's the amniotic fluid level? And we do a non-stress test. Who remembers non-stress test? Anybody know?
I do not.
Likewise.
Okay.
I
was
had a
waiting.
lot of non-stress tests done when I was pregnant with my second child.
Why did you have non-stress test done?
I had low growth rate and low amniotic fluid levels, and I was gestational diabetic.
Okay, so guys, Courtney had low growth rate. So what's the term for that? IUGR, intrauterine growth
You-
restriction.
Yes.
Okay, she had low fluid level. What's the term for that?
Oh, it's not the poly. I don't know how to say it. It's the one with the O.
Good. Yes, it's not the poly. It's the one with the O. She had oligohydramnios. And then she was high risk because she has gestational diabetes. Okay, so she had non-stress test. Courtney, how did they do your non-stress test?
It was every Monday. I went into the hospital and they checked my vital signs and they hooked me up to the monitor to just watch my baby move. So I had a button, and every time she moved, I pushed the button. And then they watched on the strip her movements and her heart rate to see if she was decelling.
Perfect. So here's the non-stress test. What they were doing with Courtney, they had her pushing the button to show when the fetal movement was happening. And then they're looking at the heart rate of the baby. And so everything we talked about in class this week, unless you guys haven't had class, if you have class on Friday, everything we talked about in class this week about fetal monitoring, that's what they're watching. So they're looking for the normal baseline. What's the normal fetal baseline?
110 to 160.
110 to 160. So they're making sure the baseline is normal. They're looking for that variability, the squiggly line. Okay. And the variations for variability is between 5 and 25 beats around the baseline is normal. And then they're looking for at least 2 accelerations from the baseline. For a non-stress test, we need at least 2 accelerations, and it's going to go up at least 15 beats above the baseline and last for at least 15 seconds. And we do this, a non-stress test for 20 minutes. So in that 20-minute period of time, we want to see moderate variability, 2 accelerations, no decelerations. And that's what they were looking at with Courtney's non-stress test. And this gives us a really good evaluation of the oxygenation of her baby. And if we have moderate variability, normal baseline, no decelerations, and 2 accelerations, that's considered a reactive tracing, and that is reassuring. So that is the last part of a biophysical profile. Also, we can do non-stress tests on their own, which is what they were doing for Courtney. But it is one of the tools for the BPP. And the thing with the biophysical profile is if we do this, we give points in each category. And if the score is low, we're very concerned about that baby. All right. So it says poor findings can indicate impending fetal death. If the BPP score is low, we are delivering usually. so that we have a life.
Yeah, with her, I also had BPPs done, and I had, I think, 2 out of the many that she did not score highly, so they sent me upstairs to do the non-stress test. And then they ended up sending me home every time, but they
So
were
they
very
must have
proactive.
seen, yeah, they must have seen something that reassured them if they sent you home. But like she says, they were very proactive. Because if we get low scores, that can be a sign that we're going to lose that baby. Okay. Awesome. It helps that Courtney has this experience so she can share her stories with us.
That was a terrible pregnancy and labor, so I'm glad to entertain you guys today.
Well, it is helping with everyone's learning. And I bet your pumpkin is great now.
Oh yeah, she's 5 now. She's a beautiful little girl, sassy as ever.
Yep, we like them sassy. All right. Okay, moving on to labor and birth. So this is going to be a lot of redundance, okay? Because if you're in my classes are on Mondays and Wednesdays, and we learned about this week. Okay, if you haven't had your class this week, then you'll go to class on Friday and be like, I already know the P's, because this is the P's. All right. So the P's that we think about in labor and birth, what are our 5 P's?
Powers is one of them.
Yep.
Position.
Good.
The passenger, like the baby.
Good.
Passageway.
Yep.
And the psychological response.
Perfect. Those are your 5 P's, guys. Okay. And as we go through this term, we will reference that when we're talking about an induction of labor and we're giving Pitocin and how do I know if my power is strong enough or things like that? We reference our P's. Okay. So, and so those are our 5 P's. Now, something that can affect this is going to be the shape of the pelvis. Okay. If the pelvis, if you, I don't have it in this slide, but a gynecoid pelvis is the one that is the best for a baby to fit through. A pelvis like a platypoid pelvis that's more compressed, babies don't fit through there as much. Okay, so the maternal pelvis shape can affect labor. So can the fetal head. So in class, we talked a ton about the position of the baby and OP versus OA and the attitude and are they flexed, are they not? So the fetal head is if they flex, if they're coming through with the more narrow part versus the wider part, all these things affect labor. They affect the birth. They affect the ability to get a baby out vaginally, which is where changing mom's position helps. I can't change the shape of the mom's pelvis, but I can put the mom in certain positions that help the head and the pelvis fit together better. Okay. Signs and symptoms that labor might be starting. Any idea?
The baby drops.
Baby drops. What is that called again?
Lightning.
Lightning. Okay. That can be a sign. Mom suddenly goes, wow, I can breathe so much better now because now the head is engaged in the pelvis and the baby is less so up in her ribs. Okay. What else?
The contractions are closer together.
Okay. She's contracting. All right. Those could be Braxton Hicks, but now they're getting stronger and closer together. Sure. The cervix will probably start softening. So as the cervix softens, the cervix has little capillaries that live in there. And as it starts to soften, sometimes we see some blood on their tissue. Normal can be a sign that labor is going to start. Okay. And actually, if we're trying to induce labor, we might have to artificially soften that cervix. And the body softens the cervix with prostaglandins that live in the body. And if we're inducing labor, we can artificially do that with prostaglandins as well. We'll learn more about induction of labor in week 6. All right, so stages and phases of labor. How do I know my patient's in labor?
The contractions are regular and more intense.
Good. Cervical change. Cervical change is the big one. All right, but definitely the contractions being regular and increasing in intensity is a really good clue that we're changing the cervix. If the contractions are irregular, if we send her walking and they space out, if we hydrate her and they go away, if they change with position, things like that, it's probably not true labor. But we're going to know it's true labor if her cervix is making change. Okay, so stages and phases of labor. What's our first stage?
They're fully dilated.
Okay, so the dilation from the beginning of labor to full dilation is the first stage. And then we have phases that happen in the first stage. Do you remember what the phases are?
Latent, active, and transition.
Okay, latent, active, and transition. And what is each one of those? What's latent? Early labor. Okay. Latent is usually when we're getting just a little bit of cervical change. It goes slow. This is the longest part of labor. Okay.
It goes until 4 centimeters, is it?
Depends on where you look, because they've kind of changed that from 4 to 6. And so Katie, no, it's not. Lori has both books, and I have to look at what the new book says, but the book that she has the paper copy of says both in the book.
Okay.
So in one spot it says 4 and in one spot it says 6. I wouldn't get super caught up on that number. Just know that in active labor, we're making really consistent cervical change. Okay. In latent labor, it's a little more irregular. All right. So depending where you look, between 4 centimeters and 6 centimeters is the active phase. And then what happens in transition?
The intensity is strong.
It's strong. Okay. What else?
Contractions every 2 to 3 minutes.
Okay. What does mom feel like in transition?
Really painful.
Really painful. This is when she starts, the head comes down and puts pressure on that Ferguson's reflex and causes her to really want to push. That's transition too, is that urge to bear down. Okay, all of these are part of the first stage. What's second stage?
When you're actively pushing.
Okay, pushing. And second stage ends with what?
The delivery.
Delivery.
Of the baby.
Yep, delivery of the baby. And so things that we think about for second stage. If she's pushing, it might be 1 contraction, it might be 3 hours. I don't know. All right. And so if she's pushing for a long time, let's change her position. We don't need to just push on your back all the time. In fact, getting her upright, having her push like in a squatting position, even patients like that have an epidural, I'll put a bar on the bed and have them hang onto the bar so they can squat. Getting her upright helps with the descent of the baby. Non-medicated patients can even push in a standing position. Okay. And if I can't get her upright, I'm putting her like on her side to push in different positions to try to bring that baby down. Okay. So second stage, there's a lot that goes into getting that baby down and out. All right. So second stage, we had a baby. Now what happens for third stage?
She has to deliver the placenta.
She has to deliver the placenta. Okay. So placenta, how long do we wait for a placenta to come out?
5 to 30 minutes.
Good. All right, as much as 30. We need to, the provider is going to be right there actively managing this part. Okay, we're not just going to be like, oh, the baby's out, look how cute. Somebody is making sure that placenta is doing what it's supposed to do, because when the placenta separates and comes out, number one, that we need the whole placenta to come out. Next week in class, part of the discussion is how retained placental fragments can cause the uterus to not contract properly and cause her to hemorrhage. Okay, so we need the placenta to come out whole, and we need the uterus to contract down right after the placenta comes out. And so we have a provider expectantly and actively managing the delivery of the placenta. And so typically in a delivery, you have one nurse that is the mom's nurse, and you have one nurse taking care of the baby. And so that one is helping the family go, oh, how cute, and snuggle and skin to skin and all the things we'll learn about with the newborn. And then the mom's nurse is participating in the active management of the third stage. Okay, so now we delivered a placenta, and now we're in the fourth stage. What's the fourth stage?
Kind of that recovery time, so the first few hours
Yeah,
after delivery.
it's the recovery time. Her body just did something crazy hard. And so we need to manage her blood pressure or monitor. Sorry, we don't, hopefully we're not monitoring her blood pressure, monitoring to make sure her uterus is contracted down. We're monitoring her bleeding in those first 2 hours. And that's also the baby's newborn transition as well, which we learn about later with newborn, but they all kind of go together. Okay. What if though, so we have a patient we just did all those stages of labor with. What if though, instead we determined that she wasn't in labor? What if her contractions were irregular and I got her up and I sent her walking and her contractions spaced out and we rechecked her cervix and she didn't make change? What would that patient do?
False labor.
Say that again?
False labor.
False labor. So if it's false labor, if she's not changing her cervix, what would we do for her? I mean, she
Send
can't
her
live.
home
I was going to say, she
or
can't live
induce.
there. Okay, we would either need to send her home or induce. Most often, in my experience, we don't automatically induce. Inductions are scheduled. We only induce if there's a medical indication. So if I had a patient that came in and we monitored her and she wasn't changing her cervix, she had signs of false labor, as long as we have a good NST that's reactive and reassuring, she can go home. And we give her a lot of really good education on comfort measures at home, when to come back, things like that. If it's a medical indication, then they might keep her and induce her. And then we're thinking about the prostaglandins to soften our cervix and all that stuff that we'll learn more about. Okay. All right. So when we think about how we are supporting moms in labor, pain management, how they perceive their pain, all those things. A lot of this stuff we touched on already today at the beginning, because I don't think that for patients that have cultural considerations for pain management, for patients that have a history of sexual abuse, things like that, I don't think that that is specific to just when they're delivering. These are things we're taking into consideration at every appointment for them. Okay, so we kind of touched on this stuff already at the beginning when we were just doing their original assessments. Okay, so these are all things we're taking into consideration and we're thinking about with our patients is their perceptions, whether it's cultural, whether it's past experience, those things. Non-pharmacological pain management. What are some things that we can consider for our patients that are in labor or even actually, guys, sometimes those Braxton Hicks contractions are rough and patients are like, but this is really uncomfortable. What should I do? What are some things we can teach them?
Ice and heat packs, reposition.
Good. Repositioning, heat or ice, like heat or cold.
Sometimes compression helps.
Compression helps, yeah. What
Like
else?
Aromatherapy, music, water.
Massage.
Excellent. Okay. And so a lot of these, what works for one may not work for another. Okay. But these are all things we're suggesting or that we are helping with. And a lot of them are going to be building on the idea of the gate control theory. And so I talked about gate control theory in my class this week. Does anybody know what this is?
It's kind of like just the distraction to block off those pains, kind of doing things. I know personally for me, sometimes when I'm hurting, I'll like read, and that next thing I know, that pain is gone. So something like that to help them. I think I heard one woman tell me when she was giving birth, she did her makeup, and that helped
Wow.
with her pain.
That's good. That's a great idea. So it's really about distraction. Okay. And so a lot of the things we're doing, even massaging, therapeutic touch, aromatherapy, a lot of this stuff provides a distraction. And it also, anything that promotes the brain to recognize positive chemoreceptors is going to make the brain not notice the negative or the pain as much. Okay, so these distractions block the nerve pathway. So the idea behind the gate control theory is that the nerve can only handle so much stimulus. And so if you saturate the nerve with something that is positive or distracting or whatever, it doesn't, the impulses that carry the pain to the brain, it doesn't make it as much. It doesn't notice the pain as much. So that's kind of the idea behind gate control theory. When I learned about it in relation to the chemoreceptors in the brain, noticing positive as far as there's certain things that trigger positive. So massage is one of those things. Massaging certain places like in the palms, on the shoulders and the back, the soles of the feet. There's positive chemoreceptors in the thighs. So women that sit on a ball and kind of rock on the ball, it stimulates positive chemoreceptors, and so it blocks that transmission of the pain. So it's all about distraction. Okay. Pharmacologic options. So what kind of things can we do pharmacologically to help women with pain management in labor?
Morphine.
Okay. We can use medications like morphine and Stadol, fentanyl. The thing with this, with medications, is are they going to cross the placenta to the baby? What do you think?
Yes.
They will, right? If I give her an IV dose of any of these medications, it's in her bloodstream, which means it's going to cross to the baby to the placenta. Now, that is typically considered safe. We monitor the baby continuously during this time. However, if we're close to delivery and I give mom morphine, Stadol, or fentanyl, then I can cause respiratory depression for my baby because it crosses the placenta. Okay, so that's gonna be one of the things we consider. For anesthesia, what type of things can we do to help mom with pain management with anesthesia?
Epidural.
Epidural is the most common one.
A
Okay,
spinal tap.
what's that?
A spinal.
We could do the spinal, and most often we do the spinal if we're doing like a scheduled C-section, where we know for sure we have a definitive end time, because the spinal is really only going to last like 2 hours. Okay, so if we have a definitive end time, then the spinal is a great way to go. If we have an indefinite amount of time that we need pain coverage, the epidural is going to give us, because it's going to continuously infuse medication into that epidural space. So what are some considerations with epidurals and spinals?
Sometimes there can be a CSF leak.
Sometimes what?
There can be a CSF leak.
Okay, cerebrospinal fluid leak. So what Katie's talking about is when they place the epidural, if they accidentally nick the dura, then cerebrospinal fluid can leak. If that happens, what might we see?
Spinal headache, right?
Major.
Spinal headache. Yeah, spinal headache. And I'm not going to see that spinal headache today because the leak is very slow. This will be something we see later. Okay, usually she's had her baby, she's on mom baby, and then she notices that every time she sits up, she has this excruciating pain in her head. And that's like the classic sign, is if she lays down, she feels okay. If she sits up, the pain is really bad. Okay, so that is a risk for sure. Small, but definitely can happen. What else? What is the most common thing that can happen with an epidural or spinal that we would be concerned about? I don't know if I have it on the next slide. Nope. What do you think?
some type of nerve issue, maybe?
Not quite. We have all these quiet people on this backside of class. Does anybody have an idea of the most common thing that can happen that I'd be concerned about with epidural placement?
Like
Is it like back pain?
Well, it's a good guess. The one I'm most worried about starts with an H. Hypotension. Why am I worried about hypotension? Do you think?
Because then they're not perfusing as well in the baby.
Good. All right. It affects the perfusion to the baby. Also, they might feel like garbage. If they become hypotensive, they might be vomiting and feeling bad. But mostly, I'm worried about how that affects her perfusion to the baby. And hypotension is the main side effect that we can see with an epidural and a spinal that's concerning because of the perfusion issue. So we're going to give a fluid bolus to moms before we do the epidural to help support their blood pressure. And then we're positioning mom on her left side for good placental perfusion and monitoring that blood pressure. And that's one of the things we think about when we have decelerations. And we think in a minute, we'll look again at what we learned about fetal monitoring is if one of our considerations is the blood pressure low? Do I need to treat the blood pressure? Okay. Other things with an epidural or spinal, she's not steady on her feet now, so she's a fall risk. Okay, so when you're doing your nursing care plan, risk for falls related to epidural placement or decreased sensation to lower extremities. Okay. What else? Oh, her bladder. Her brain's not going to see that the bladder's full, and it's not going to do a very good job releasing urine. So most often we do a catheter. All right, fetal monitoring. So the whole idea behind fetal monitoring, why do we do it? What's the point?
Make sure the baby's not in any distress at any point.
Okay. And what if the baby's showing signs of distress, then what am I worried about? Worried about their oxygenation. Because if the baby's oxygenation goes down, if they become hypoxic, they can develop acidosis. And the acidosis is going to not be good for their body, and it's going to be detrimental to their organs and especially to their brain. Okay, it can cause encephalopathy, it can cause cerebral palsy, stuff like that. So everything we do with fetal monitoring is just to determine the oxygenation of our baby. Okay, we can do external monitoring and internal monitoring. Our external monitors are on the belly. Internal monitors go inside. So we need the cervix to be open enough that I can put my monitor inside. So for our tracings, when we're looking at when we're doing fetal monitoring, we already determined our normal baseline is 110 to 160. All right, and then we talked about the variability. I think I have pictures. Nope, I don't have pictures of variability, but guys, the idea behind this is that the variations around the baseline should be between 5 and 25 beats. Okay, and it doesn't follow a specific pattern. It just has those variations. That's moderate variability. The things to know for your accelerations and decelerations is going to be the same as when we were doing the non-stress test. Okay, so our acceleration should be between 15 beats and 15 seconds. This is an example of a tracing where I have contractions down here. I have a baby up here. The baseline is this, and I don't see any variations. So my variability is not good. And then I have these decelerations. And these decelerations, what do you think? Just based on what you guys learned in class, what kind of decelerations might those be?
It looks like late.
Normal?
They look like late. Why do you think they're late?
Because they're after the mom's contraction.
Day after mom construction, right?
All right, did everybody hear why that's a late deceleration? They are starting after the contraction starts, and they're not returning to the baseline until after the contraction's over. They're late. All right. So here's examples of early and late and variables. Earlies happened at the same time as the contraction. They mirror the contraction. Does anybody remember what causes an early deceleration?
Head compressions?
Head compression. So am I worried about early?
No.
No, I'm not worried about an early. Okay. What about these variables? See how it has an abrupt onset and drops down and makes a V shape? What causes a variable deceleration?
Cold compress.
Cord compression. Good. Am I worried about a variable deceleration?
I would say for long periods of time, yeah. But I mean, would that be just like you try to move them to get off the compression wherever that's at?
Perfect. Okay. If I have occasional variable decelerations, I'm getting some transient pressure on the cord, I can move the mom and try to shift so that we relieve that pressure. So I'm not definitely worried right this minute, but if it continues, I mean, I definitely should do something. And Anna's right, I should move mom. All right, what about our late decelerations? What causes our late decelerations?
Placenta insufficiency.
Good. Okay, so when I say she just got an epidural and her blood pressure is 80/30, and now I have late decelerations, well, her blood pressure is low, right? So now I'm not perfusing the placenta well, so I have a placental insufficiency, and it's causing late decelerations on my tracing. And I know they're late because at the onset happens after the contraction starts, and then it doesn't resolve until after the contraction ends. And then here's your accelerations, those increases. When we talked about we wanted 2 in 20 minutes for our non-stress test, that's what an acceleration is. Greater than 15 seconds, greater than 15 beats. Okay, so if we have late decelerations or if we have variable decelerations, these are our interventions. And so worth noting, and we didn't discuss them because they're not in the pictures, but also guys, a prolonged deceleration is going to be a dip that lasts longer than 2 minutes. So this dark line to dark line is 1 minute. So in the pictures, these were all ones that resolved in less than 2 minutes. But if I have heart tones that go down and stay down for an extended period of time longer than 2 minutes, I can do my interventions. I can change her position, give her fluid bolus, give her oxygen, do all the stuff, but I should be getting the doctor on the phone and into the room. Okay, because sometimes a prolonged deceleration can be resolved by the time the doctor gets there, and that's usually what happens. But if I don't get it resolved, if I've done all my interventions and those tones stay down, we might need to go have a C-section. Okay, makes sense? I mean, a baby's heart rate can't hang out at 80 forever because we're not oxygenating well that way. That'd be like you living life with your heart rate in the 30s. You're not oxygenating well. Okay, so if I have prolonged, if my decelerations are lasting longer than 2 minutes, do your interventions and get your provider in the room. And so these interventions are going to be focusing on depending on what's causing our decelerations. So stopping Pitocin and doing tocolytics are going to both be ways to slow the contractions down, because every time the uterus squeezes, I have less blood flow to the placenta. Position change is going to do 2 things. It's either going to shift a baby off of a cord for those variables, or it can also increase placental perfusion for those lates. Oxygen I can oxygenate that mom all day long. If I'm not perfusing the placenta, it's not going to help much, but it is still on the list. IV bolus is great if the blood pressure is low. And if the blood pressure is below 20% from the baseline, which most often we would see this like with an epidural placement, we need to treat it. Okay. I'm still going to change mom's position to help with perfusion. I might give an IV bolus, but we'll probably give medication also to help reconstrict those vessels and bring the blood pressure back up. So the other way to look at it is like this. It's the same information, it's just in a different graph. Okay, we're using veal chop mine. So V is variables. We have an abrupt onset caused by cord compression. Let's move them on. E is early. The decelerations are mirroring the contraction or happening at the same time. They're caused by head compression, and we don't need to do anything about that. Intervention is not needed. A is accelerations. We like it. It's okay. No interventions needed. Late decelerations are after the contraction onset, placental insufficiency. Let's do all of our things. We're still going to move mom first, but we should be doing these other steps to try to resolve our decelerations. Make sense?
So what's the difference between the two mnemonics with Lion and Display? Is there any like major difference that you would do one or the other, or are they just kind of?
So let's look back at this one, the mnemonic veal chop. That's the one that is everywhere. It's all over the internet. Okay. And so you can see if you write the word veal, you write the word chop, then you can see how you look across and you can see a variable's cord compression, the early is head compression, accelerations are okay, and the lates are placental insufficiency. The mnemonic that includes mine on it, it just reminds you what to do. So you can see here's veal and here's chop, and it still lines up the same. This just gives you one more step and reminds you what to do. So if you have variable decelerations, they're caused by cord compression. If we have cord compression, we should move them on. Does that make sense?
All right, I was talking about the Lion with like the intervention
Oh,
ones.
I'm sorry. You said lion. I thought you said mine. So
I kind of mumbled.
the thing with lion is that for some people, lion is just easier to remember. When I started out teaching this, there were students that had found the Lion mnemonic online. And so I include it because it is a faster, it doesn't think about contractions and how that can affect our fetal heart tracing. And it doesn't give consideration to the low blood pressure per se if we need to medicate it. But Lion is very short and sweet. Left side, IV fluid, oxygen, notify the doc. And that really is what you need to do, right? Let's change her position, put her on her left. IV fluid bolus is going to help those low blood pressures and things like that, oxygen, and then notify. So Lion is just a shorter way. If this is hard to remember, these are going to be your keys. And the reason why especially is because that the very first thing you should do no matter what is change her position.
Okay, so like less invasive to most invasive, so to speak.
Absolutely.
Okay.
Yep. I can walk in a room if I'm looking, because what happens in at least any hospital I've worked in is that you will see a monitor with several little sections of tracings happening. So I might see however many patients are on the monitor. I might see 4 rooms, 8 rooms, whatever. And so if I look at that monitor, I can easily see, because it'll highlight what the normal is. So like in here, the blue is 110 to 160. I can look up at a monitor and I can easily see, is the baby in the normal range? And what kind of deceleration is happening. And if I see a deceleration happening, regardless if I'm seeing these or I'm seeing this, the very first thing I'm going to do when I walk in the room is move mom. First thing, because it's very easy and very quick. If my If my deceleration is variables, moving mom will change the pressure on the cord. If it's late, it's going to change the perfusion to the placenta. So it's very non-invasive, very fast. I can do it now, and then I can look at that tracing and see if it helped, and then decide what to do next. But this one, the spoiled pneumonic, gives us a better idea of the other things we should consider. So the next thing I would do, in addition to moving mom, I would start an IV fluid bolus. I would turn off the Pitocin. And if I'm not seeing an improvement in my tracing, I would probably call the doctor and start grabbing these other things, like grab the tocolytic we usually use is terbutaline. Somebody will go grab terbutaline. Somebody will go grab ephedrine for the blood pressure. We'll cycle the cuff. What's her blood pressure? Is it 20% below her baseline? So sometimes we're doing a lot of these all together at the same time. But that's kind of the idea behind it. So I hope that helps.
Is spoiled and poison the same thing?
Is what?
Spoiled and poison the same thing? My sim teacher taught me poison, and it
haven't
seems
seen
to line
poison.
up. I have it on my phone. I can't remember all of it, but it seems to be the same thing.
I haven't
I just
seen
don't-
poison. P would be position change, O's oxygen, I's would be IV bolus, then S is stop Pitocin, N is probably notify. I like this one because it considers the low blood pressure and it considers the tocolytic. But I wonder what the other letter of poison is.
Okay, P is position on left side. O is oxygen, 10 liter per non-rebreather.
Yep.
I is IV bolus. S is sterile vaginal exam. O is oxytocin off, and N is notify the MD. I just wanted to make sure that I'm not
You're
not
fine
making a
either way.
difference between
No,
the two.
you're fine either way. Because the idea of doing a sterile vag exam is if I'm having a deceleration, it might be because the baby's coming down. And so checking the cervix is one of the things we do. It's just not on our list for this.
Okay, thank you.
So position, oxygen, IV bolus, sterile vag exam, and notify. So that does not give consideration to what our contractions are doing. So stopping Pitocin if we're running it is a good idea too, because every time the uterus contracts, I have less blood flow through the placenta. Okay, but yeah,
Makes sense. Thank you.
poison works. I like it. Okay. All right, so we're not going to do another case study, okay, because in the interest of time. Test taking strategies. Guys, when you're taking your exam, just really try to break down what it wants to know. Okay, so your select all that apply questions. These are the ones that's everybody's nemesis. That seem like they're the hardest. Break it down. Sorry, I'm changing my seat. Break it down. So what does it want to know? And so take the stem of the question and then take your answer, put together. Is it true or is it false? Break down each part of it. Okay, you can try rephrasing questions into your own words so that you can pull out the necessary information. Don't play the what if game. Well, this might happen on Sundays when the sky is blue is probably not a right answer. Okay, prioritize your questions. So usually, guys, we're going to go ABCs and we're going to consider Maslow's hierarchy of needs. And most of our interventions should go least invasive to most invasive. Okay, so depending on the situation though, sometimes we have to intervene right away. Sometimes we can have an assessment or whatever. So just really take what it's asking, take whatever information it gives you and decide what needs to happen. But don't read into it. Don't overthink it. Just take it at face value. Whatever's in the question is the only information to consider, not anything that you can, again, well, you know, on Sunday that might happen is probably not it. And then there's math. There are 5 math questions. Okay, so think about things like conversions, grams to milligrams, micrograms to milligrams, milliliters to ounces, pounds to kilos. Doing a lot of the math stuff we did in the first math assignment, those are the type of things you should make sure that you know how to do. Okay. Underneath the cute puppies is 50 questions, answers, and rationales. So you can, on your own time, go through these. And here's the question, here's the answer, and here's the rationale for why that's the right answer. And so you guys can spend time in these as well. Okay? And
Professor,
that is it. Yeah.
if I'm not in your class, can I see those questions too?
So I put, do you see in the chat, I put this PowerPoint in the chat. If you scroll back, it says 9:58 for me is when I put it in there. Do you see it?
Oh yeah, I saw it. Thank you.
Okay, so you can grab it and all those questions are in there.